I see all day, is I've tried this, I've tried that, and the root cause was usually missed. And I thought this was true foot drop, right? And they had like you could see it, 3+ out of 5 strength, something like that, right? And then I opened up their SI joints and they, boom, 5 out of 5 strength. And that, to me, to my knowledge, that's not documented anywhere. I just discharged a woman, and in my sacral paper, I wanted to bring awareness to my colleagues about how bad these people are and like how debilitated they are. They can't do anything anymore, they say. They can't stand up. They can't get around the grocery store. What is the point? Hey everybody, what's up? Physical therapist, Dr. Ryan Whelton, coming to you from just outside the beautiful Tampa Bay area. If you're new to following me, I got a chronic pain clinic. A lot of my patients, like in my published papers, I wrote what they tried. That's like the type of clinic I have, what I see all day, is I've tried this, I've tried that, and the root cause was usually missed. So that's what I've been doing is the past better part of a decade, I have been on here teaching my methods, Whelton methods, and then also I have all my courses and I have my membership, my VIP group, where I'm teaching live. Now I'm going to be teaching live again, and it'll be interactive, so you can ask me questions and we can go through cases together. And it's going to be really cool. I can't wait for it. Now, let's see here. Oh, by the way, you can follow me on, if you want to watch the full length of this, if you're just watching a clip, you can follow me on Spotify and watch the video. YouTube, watch the video. Whelton Methods is the name. Click subscribe. And then also Apple Podcasts, you can listen. I don't think you can watch on Apple Podcasts, but you can listen. So anyways, let's see here. So, breaking news from Whelton Methods. I just published clinical guidance on 10 more orthopedic conditions. And the way that I did it is I don't want to write like paper after paper after paper after paper. So and a lot of stuff I've seen over the years, and I developed protocols to help it that I published, but there's certain conditions that it take me forever to see that many people, to publish a study on it, So, because I mainly have an SI joint, low back pain, chronic pain clinic. Most people have 2 to 3 issues, which is why I end up treating, some of these other issues, is because they're like, oh yeah, by the way, my foot hurts, I got, metatarsalgia, that, this, that, the other thing. But the journal told me that they would just add it into my papers. I wanted it all right there. So I published root cause of SI joint dysfunction. I published root cause of sacral torsion shear, with both have novel diagnostic methods in there. I published, what else did I publish? I published root cause of plantar fasciitis, and then I published posterior impingement syndrome with all kinds of other orthopedic conditions and methods to help with that. And I just added these 10 more conditions in there with my clinical guidance on how to help these people. Okay, so go over there and check it out. One of the things that I put in, I believe, my SI paper, one of the things that I put in there is trochanteric bursitis. So I have noticed over the years of doing this that very high percentage of SI patients complain of hip pain. Now, if you don't palpate trochanteric bursitis, you can't say it's trochanteric bursitis, but because that's, to me, the most effective way is to palpate it. But most patients with SI have difficulty laying on their side. They can't lay on their side because, read my paper on wheltonmethods.com. All my papers are on wheltonmethods.com. You can find them there. And upslip and or outflare. But if you look at the anatomy, it's just shearing bone pain. So of course it hurts to lay on their side, right? It's one of their main complaints, which I wrote up in my updated version of my SI protocol. So in order to diagnose, the way that I diagnose it is if they have hip pain and then you palpate, you find the greater troch, just wiggle the person's foot in and out, find the greater troch and then palpate above that, and they usually jump. and they're tender, okay? But I noticed, which I wrote in the paper, I noticed over the years there was a very high correlation with these people with SI joint dysfunction, and specifically gluteus medius weakness, which when weak causes an upslip myomechanically, up like that. So gluteus medius goes from here to here, strengthen it, brings it down, right? As part of my SI protocol. But I noticed over the years that patients that I would put on my SI protocol they would get better, their bursitis would go away. So I started to key in on the fact that that was, I would say the main factor was the gluteus medius weakness part of it, creating a tendonitis or a bursitis type issue, an inflammation overuse issue because of the weakness. So I put that in the paper so you can read it, wheltonmethods.com. Go read my papers again. I updated them all, okay? 10 more orthopedic conditions with protocols, okay? Now, so trochanteric bursitis, I don't even worry about it, to tell you the truth. I don't worry about it because when someone has trochanteric bursitis, I don't treat it any differently. I just put them on my SI protocol because I find they usually have SI joint dysfunction. So I'm just putting them on my SI protocol, and that usually just takes care of that. And they're not tender anymore to touch at their greater trochanter, okay? So, or above the greater trochanter at the bursa. So what is happening with these people is, with trochanteric bursitis, is you have your femur, acetabulum right here, and the bursa sac gets inflamed, but the gluteus medius is right here. And if you test your SI joint patient's strength, you will find that the side with the upslip has gluteus medius weakness, okay? Because that's what causes biomechanically an upslip, is gluteus medius weakness. Now, I've only seen an upslip on one side. I've never seen it bilateral in my entire career. But most of the time, they usually have bilateral out flares, I find, okay? So they're flared out like that, and then that can cause pain there. But also you can get hip pain, mysterious hip pain, from SI joint referred pain, okay? And so you have to take that into account too. So what I do is I realign their SI joints first, and I pull in their leg, gap open their ASIS, realign it, and then ask them if that hip pain's gone. But if it's still there, you just touch. Go ahead and just touch in there, and if it hurts, if they're pinpoint tender to touch, then they got bursitis, okay? That's how I diagnose it. So I don't need to see imaging really, and I'm not too worried about it. I just put them on my SI protocol, and they don't have hip pain after, type thing, like in my paper. So, okay, so SI joint dysfunction, though, you have to make sure that you are diagnosing it accurately, okay? So read my paper, wheltonmethods.com, root cause of SI joint dysfunction. I identified that it's caused by an upslip and or out flare, up, out, okay? So you put this bone on this side too, put both of your thumbs on the PSIS and just wiggle your thumbs over it, and it kind of snaps on and off, and have the person extend back. I do standing extension. You can do pro and press up, and then have them extend back, and the thumb that translates superiorly has an upslip, like that, okay? And the reason why it's translating superiorly is because it's locked. So it's going up like that. It's not going down with the sacrum, okay? So it's locked. So you can get rid of that immediately just by pulling on their leg, okay? So you pull on their leg, and then you lay them on their, so then you recheck again. So you check to see if they still have an upslip. So you ask them to extend back. One thumb doesn't rise anymore, it drops down. Both of them drop down. Okay, I got the upslip, but they still usually have pain, especially in the chronic pain world. So then you lay them on their side, and you can watch all these videos I have on YouTube showing this. I put out videos constantly showing how to diagnose and treat this, other than my papers. Plus, I have all my courses where I go much more in depth. But what I do is I go like this and lay them on their side. I take a hydroculator pad, I put it right here, and I go like that, and I gap that open. I do it for like 30 seconds. And I have them stand up and ask them, do they still have the pain that they had before? So first you got to test, what are their hurts in extension, where their hurts in flexion, quadrant test, whatever it was, right? And then I ask them, do you still have that in extension or flexion or quadrant test? If they say yes, what I do is I put a ball between their knees and standing, like a kickball, something they can squeeze. And I wrote this in my paper too, that they squeeze and then gap it open like that, okay? And then I'll have them extend back again or flex or whatever the aggravating motion was. Does it still hurt? No. Okay, I got it. Yes. Okay, well, then I just add over pressure right here, okay? And I hold it open, and then I have them extend back or bend forward. But I ask them, do you still have any of these, referred pain going on, okay? And you will see the craziest referred pain patterns, okay? In that paper that I just updated, my SI paper, read it, on my website, wheltonmethods.com, I actually put 2 YouTube videos in there of foot drop cases. These people came in with foot drop, and I thought this was true foot drop, right? And they had like you could see it, 3+ out of 5 strength, something like that, right? And then I opened up their SI joints, and they, boom, 5 out of 5 strength. And that, to me, to my knowledge, that's not documented anywhere. So I actually colored in down in here that it can cause weakness. And in that paper, I just updated my SI paper on my website. I just updated it, and you can get, I said you can get I've seen every symptom of a peripheral nerve lesion, including weakness in the quad, in the ankle, foot drop, quad weakness, tightness, burning, numbness, pain, obviously, from SI joint dysfunction. And then I've actually seen it in the genital region. Pelvic floor therapists, I've seen it in the genital region. I've had this year, I believe, 3 cases of testicular pain that the medical system said, we don't know what to tell you, man. And then I open up their SI joints, hold it open, and I said, does the testicle still hurt? No. Okay. And then I did the rehab, and that went away. And I was like, SI joint, although not documented, I colored in the genital region because it can refer into there. So if you are a pelvic floor therapist and you are doing this all day long, then you need to be aware that the SI joint can refer in there. So you got to hold it open, okay? After you get the upslip, gap open the ASIS immediately, okay? Gap open the SI joint, and then have them squeeze a ball or hold it open and say, do you still feel that in the genital region? If they do, then, you might be dealing with something else. But these people that I see in here are always usually ruled out. They've seen everybody. And the medical doctors do ultrasounds on them and all kinds of stuff, and they can't find anything. It was actually referred pain in these patients from the SI joint. So yeah, I've learned a lot. Once I started realigning SI joints, I started seeing referred pain patterns, and I'm just like, what? I've seen patients without back pain that just had knee pain, ankle pain, that had surgery on it. And then they were upset that they got out of surgery, and then their knee and ankle still hurt. And then I opened up their SI joints, realigned it, boom, pain was gone. And I was like, ooh, man. And then I had them do the rehab, and pain was gone. I had a surgeon in here, the foot surgeon, and I was talking to him about it. And I'm like, man, I see ankle surgeries like more than I care to. That was actually SI joint dysfunction. And he actually said, I know. He said, I know. And I'm like, wow, that's cool, because I'm just sitting here thinking like nobody's even looking for this, like to me, anybody with any symptoms, non-emergency symptoms, if you're in a car accident, you should have surgery immediately, right? That type of thing. You have a burst fracture or something like that, right? But anything from the lower thoracic into the foot, you should be screened for SI first. It takes 30 seconds, everybody should be doing this. And I published it for free for humanity so that people will do this and they will help other people avoid, not just chronic pain, but this craziness that I see that I published in my papers. I specifically, when I made that data table in my papers, my SI paper, my sacral paper, and my other papers, but my SI and sacral paper, I specifically made the data table and I wrote in what those people had tried. I've tried physical therapy, chiropractic, injection, surgery. I had my spine fused, didn't work, right? And then I do this, and boom, their pain goes away immediately. And I'm like, yep, it was SI. You had a herniated disc, but that wasn't the source of pain. The source of pain was SI joint, this sneaky little joint in the back that causes horrific pain in people. I just discharged a woman, and in my sacral paper, I wanted to bring awareness to my colleagues about how bad these people are and like how debilitated they are. And so I wrote in there, because a lot of them over the years have told me that they had contemplated ending their own life. I just discharged a woman that told me that off the jump when I evaluated her, and she's totally better. She actually said, "I don't like." She walked in here. She goes, I don't like doctors. My husband made me come here. You know, I have no use for them. I've tried everything." And when I hear that story, I start thinking SI. And then I opened up her SI. Boom, pain was gone, and I was like, man. So I showed her what was, and I rotated her sacrum back, because most of these people, read my papers, have sacral torsion and shear. And so they have a shearing pain at the base of their spine. It hurts to sit. Right in here, it's rotated, and I show you exactly how they rotate. I've only seen 5 that rotated in the other direction, where my right thumb would dip on a prone press up test. Make sure you keep their glutes relaxed when they do it. It'll throw your chest up. But the left thumb dips because it's rotated like that, so you strengthen the right piriformis to bring it back. I outline that in the paper and in my courses and all that. So anyways, I will talk about this till I can't talk anymore. I will talk about this because every single week, I see like, it's just nonstop. It's nonstop. And these people are totally debilitated. And I wanted people to see that these people are talking about ending their own lives. And in fact, in my sacral paper, I wrote in there 57%. 57% of my patients, when I asked them, before I wrote those 19 cases up, had thought about ending their own life, because what's the point? They can't do anything anymore, they say. They can't stand up. They can't get around the grocery store. What is the point? And then they had all these interventions that nobody knew what was wrong with them. Oh, let's try this, let's try that, let's try this. They end up getting worse, that kind of thing. And they've just had it. So I will talk about this till I'm blue in the face, until everyone screens these poor people for SI joint sacral torsion shear. And when it comes to trochanteric bursitis, I'm not worried about it. I just put them on my SI protocol. Like, I just republished my SI with an update. My SI protocol, I just republished it. Go to wheltonmethods.com and you can read what I have to say about all the work I've been doing with SI joint patients. I'm trying to like hone it in and help people. So that's what I've been doing over the years in this clinic. That's mainly a low back pain clinic, where people have typically failed the medical system type thing, and they're desperate. So anyways, that's that. If you want to take my courses, all of my courses are online now. I have my online rehab results course, which is my orthopedic protocols that I do in here. I have my myofascial courses, the intro shoulder course, the myofascial instant pain relief course. If you can't relieve the majority of the pain that you attempt the method, the majority of the people you attempt the method on in dramatically increased range of motion, then we'll give you your money back, no questions asked. I've been doing that since the course came out, like over a decade ago, like probably, yeah, something like that. A decade ago, I've had that guarantee, and people love it. So I had one person that commented recently that said that they tested on like 32 out of 33 people had like dramatic increases in range of motion in the intro shoulder course. So anyways, and then I have the in-depth version where I map like 1,000 pages of maps of the body. And then I have my sciatica, cervical radiculopathy, immediate relief course. And then I have, which is a circuit of points I found. And then I have my membership. Okay, so my membership, I am teaching live again. I'm excited. I can't wait to meet you all. I haven't taught live since COVID. And I used to travel and teach, but I'm going to do it in Zoom, and we're going to create a community, and we are going to work together and help people. It's a group of positive people forward-thinking people that want to get amazing results for their patients. That's what they want. So, and that's what I want for them. So I will do my best to teach and to help and answer questions. And you can even bring your patients in. And eventually I'm going to get a business group going where I am going to help business owners, help open and run these chronic pain rehab places. I teach you how to do it. I have it now. You can take my course on it, but I'm gonna create a community with that too. So really exciting. So you can go to my website, wheltonmethods.com. Everything's there. My papers are there. My updates to my papers are there. My online courses are there. My membership's there. So anyways, that's that. Peace. Love you all.